Hello, ladies and gentlemen. It's a great honor and pleasure to be here at the STAR Symposium to tell you everything about intra-abdominal hypertension, abdominal compartment syndrome. So it's about guidelines and guidance and breaking some bad habits. So this is the outline of today's lecture. Let's start with the why. It's not a stupid thing to measure intra-abdominal pressure, because if you do a PubMed search, there is an exponential increase of published literature. The bottom line of all this is that 1 in 4 patients on admission of the ICU will have an increased pressure. 1 in 2 will develop it during the first week. 5% will suffer from abdominal compartment syndrome with a high mortality if left untreated. So measuring the pressure is knowing and understanding the disease. Now, abdominal compartment syndrome is a syndrome. It's not a disease. It can occur within many disease states and conditions. Yet, some surgeons, anesthetists, don't pay proper attention to perioperative abdominal hypertension, like in this case with a perforated fiscus, abdominal sepsis, back in the ICU, receiving a bag of saline because of drop in blood pressure, drop in urine output, low CVP, or passive leg raising test. Why? Because it's kind of a reflex. Whenever something goes wrong, we believe that some fluids should be good. Now, on day 2, we see a distended abdomen, creatinine increasing, and by day 4, there is a CVVH machine because of oliguria. On day 7, there is sudden cardiac arrest because of acute mesenteric ischemia caused by secondary abdominal compartment syndrome due to fluid accumulation syndrome. Now, abdominal hypertension is a killer. Look at this patient. Distended abdomen, low tidal volume, very high peak pressures. Cardiac arrest. So what did you see in the burn unit? Severe burns, fluid overload, hypothermic, abdominal distension, very high peak pressures, low tidal volume, and suddenly cardiovascular collapse, because abdominal hypertension is a killer. But the question is, did you measure intra-abdominal pressure, and did you do everything to prevent fluid accumulation syndrome? So the question here is, are we shifting our mindset and thinking fluid stewardship? Now let's move on to some definitions on hypertension and compartment syndrome. These were first published in 2006, and this paper in intensive care medicine has been for a while the most cited article. So in 2013 there were revised guidelines, and now we are working on another set of revisions of the guidelines. Hopefully they will be out by the end of this year. Now, intra-abdominal pressure is the steady state pressure within the abdomen, which we consider fluid in character, so it should follow the law of Pascal. Normally it's around 5 to 7, like a normal CVP, but in ICU patients we can have higher pressures on admission around 10. Hypertension is defined as a sustained increase above 12, and we have some gradings, 1 to 4, with cutoffs of 12, 15, 20, and 25. Now we talk about an abdominal compartment syndrome if the pressure is above 20 with new onset organ failure, dysfunction, usually the kidneys, and cardiorespiratory problems. Now, a primary compartment syndrome is when there is a primary condition within the abdomen. Secondary hypertension or compartment syndrome is when it's usually related to massive fluid overload and capillary leak and sepsis and in burns, or in the case I presented. And recurrent is more like a chronic situation that we know from the frozen abdomen. Now, we should screen our patients for risk factors, and they can be related to abdominal wall compliance, increases in intra-abdominal volume like ascites, intraluminal volume like gastroparesis, colonic pseudo-obstruction, or related to massive fluid resuscitation. Now, when it comes to risk factors, we recently published this paper in a Nature Group journal on anthropometric data. And we measured lots of parameters of the human body, normal and in abdominal hypertension. If we focus on the key predictors for abdominal hypertension, that's first the sagittal abdominal diameter, and second, if you have the xiphoid and the pubis, and you have a straight line or a curved line. Now, the difference between the straight and the curved line has been shown by artificial intelligence and machine learning that those are the main drivers to predict abdominal hypertension. Now, let's move on to the measurement. How to measure, because it's essential for diagnosis. Unless you're a surgeon, you cannot measure intra-abdominal pressure by putting one hand or two hands and shaking a little bit. Why? Because it's not sensitive nor specific, but surgeons claim they can. Also, the abdominal perimeter has been shown not to be reliable. Now, if you look at the abdominal cavity, it's primarily fluid in character, and some forces do play a role, like gravity, the uniformity of the compression, shear stress, and contractions of the abdominal muscles. I told you it's fluid in character, so we can assess and measure the pressure wherever we are within this compartment. Now, standard, we measure through the bladder, and we express it in millimeter of mercury, patient in supine position at the end of expiration with the zero at the level where the mid-axillary line crosses the iliac crest. There are some commercially available kits, and if we look at all the methods, either direct into the peritoneum, indirect via the bladder or the stomach, nowadays we have the possibility to monitor continuously. It seems logic. We have the 5 vital signs like heart rate, blood pressure, SATs, respiration, temperature. Why not adding the 6th, continuous intra-abdominal pressure, and the 7th, urine output continuously to that? Maybe we are at the verge that this technology is ready for prime time, and I can give you 10 good reasons. You can find them in this open access papers. Now there is this trauma guard catheter who has 3 balloons, a sensing balloon, a protecting balloon, and a retention balloon. It's a balloon-in-balloon technology. You connect it to a smart cable which fits into any regular bedside monitor. Now, just hot from the press, we published our first in human validation with the trauma guard in critically ill patients. We looked at different positioning like reverse Trendelenburg and head of bed elevation. Overall, we found a good correlation between continuous IEP with the trauma guard and the gold standard Foley manometer method. Now, when it comes to future guidelines, we prepared for these with a cross-sectional survey, looking at maybe new definitions when it comes to the pathophysiology of intra-abdominal hypertension, like the polycompartment syndrome, organ-organ interactions, and how we can use dynamic tests like a respiratory abdominal variation test to assess compliance. Other statements for the measurement, I think in the future will include continuous intra-abdominal pressure measurement techniques. As well as for the definitions, there are probably differences when it comes to the timing and the speed of increase in intra-abdominal pressure. So we need to separate between the duration of EHA and the underlying pathology. When it comes to the management, we will discuss different medical management options. So now I told you what it is, how to measure, but is it of any importance?
And what's your name? Marnie. Your husband's pancreatitis is causing swelling of all the abdominal organs.
Another 50 of Lido?
Pushing it. He doesn't need cardiac meds. He needs to be decompressed. Luca, you know I'm right. Pickups 2 sets. Track superficial layers.
Doing CPR.
He won't need it after this. Back inside us with a pulse.
So what did we see in this fantastic and realistic episode of ER. We saw a patient with acute pancreatitis, abdominal fluid, very high intra-abdominal pressure. There was cardiac failure, cardiac arrest. There was no return of spontaneous circulation, ventilatory failure. The pressure measured directly here was about 30 millimeters of mercury. So it's a primary abdominal compartment syndrome. And there was restoration of organ function upon decompression. So I told you that 1 in 2 of our ICU patients will develop hypertension. When we look at the abdominal cavity and when we give fluids, there will be ascites, there will be swelling of the intestinal organs and abdominal distension. Now, this increase in intra-abdominal volume and intra-abdominal pressure will compress the venous return. This reduced venous return, reduction in preload, will result in a reduction in cardiac output. And by so, during the forward failure, there will be compromise of the kidneys and the gut. A diaphragm is pushed upwards, and this will compress the lungs, resulting in difficult ventilation and breathing. With the bladder being centrally in the abdomen, we can measure the pressure through the bladder. So now all the fluids that we give will end up in the second space and the third space. This will lead to bowel edema, abdominal hypertension, compression of the vena cava, reduction of venous return, reduction of cardiac output, and forward failure. This will lead to multisystem organ dysfunction and triggering a vicious cycle where we need to give more fluid to get things going. At least that's the perception. Now, when abdominal pressure increases, there is dramatic impact, not only on the organs within the abdominal cavity, but far outside, like the heart, the lungs, and the brain. And just to list the cardiovascular effects and the respiratory effects, the list is even longer. I will not go into detail, but basically it affects all organ functions. Now, in the case, we saw that fluid overload can lead to fluid accumulation syndrome, and this is referred to as a global increased permeability syndrome of the Michelin-Man, which also has a negative impact on end organ function. Now, what can we do about it? So the medical management consists of evacuation of intraluminal contents, intra-abdominal fluid contents, improving abdominal wall compliance, correcting the positive fluid balance, and optimizing systemic regional perfusion. Maybe there is a sixth one, which is, of course, is decompressive laparotomy if all medical management fails. Now, with the Abdominal Compartment Society, we have listed the different levels of medical management as well as the different steps. So let's dive into a stepwise approach of evacuating intraluminal contents, so nasogastric tube, prokinetics, diminish enteral nutrition, maybe stop enteral nutrition. When it comes to assessing free fluids, we can go for ultrasound, maybe CT, have a drainage, or surgical evacuation. Improving the compliance we can do by sedation, analgesics, removing constrictive bandages, eschars. Body positioning is also important, and maybe neuromuscular blockers. And when it comes to optimizing fluid strategization, go for restrictive, withholding, withdrawing, and then suddenly go for de-escalation. Maybe we can use hypertonic fluids, colloids, and then diuretics, furosemide stress test, and CVVH. Optimizing perfusion by maintaining abdominal perfusion pressure, maybe with early vasopresses. So we have this nice stepwise approach on the 5 levels or pillars of medical management. And if all this fails, then you can call the surgeon for a surgical decompression. So to wrap things up, I use abdominal pressure daily in the clinical practice to assess organ-organ interactions, to assess preload status, functional hemodynamics, and passive lag raising. It has an impact on gastric function. It is the missing link to understand cardioabdominal renal syndromes in patients with worsening renal failure. It is useful to adapt the stool protocol, the speed of enteral nutrition. Think about abdominal perfusion pressure or renal perfusion pressure. It impacts on liver function, will increase lactate. Very important impacts on the respiratory system when it comes to recruitment, lung protective strategies of setting the best PEEP. And there are also some hormonal effects with sodium and water retention. Now, I would like you to go home with the knowledge that clinical estimation is unreliable. You need to measure the pressure in order to detect hypertension. Use the technique that your nurses will use. It occurs in 1 in 4 on day 1 and 1 in 2 within the first week. Think about risk factors, the body anthropometry, and it has an enormous impact on end organ function, outcome, and how we treat patients at the bedside. So why wait? Act now and start measuring intra-abdominal pressure. For those who are interested to learn more, there is a whole book about intra-abdominal hypertension, as well as compartment syndromes, and a clinician's guide available under the open access. So join the Abdominal Compartment Society now, or maybe also join the International Fluid Academy, and stay tuned, as in September, October, we have some webinars on misconceptions of fluids, as well as the latest SECAM guidelines, part 3 on de-escalation. Thank you.